Now, today is the 20th session, e-webinar of Kanun ke Pathshala. We all know that litigation cases are increasing by leaps and bounds and continue to rise further with the recent CPA of 2019. Unfortunately, the obstetrician and gynecologists rank top, and 80% of the cases are obstetric related, as there are two litigants, the mother and the unborn child. The only way to reduce and prevent the litigation is to be aware with the legal implication of if the standard of care is not provided as per the protocol and guidance to manage the case. Ignorance of law is no excuse, hence it is of utmost importance to remain updated about the various SOPs and guidelines of the condition, and equally important is to have the medical legal knowledge to prepare, prevent and protect from litigation to have a safe practice. The topic for today's session is very important and focused. That is the panel discussion on the medical legal aspect of GDM. Ask the expert. And in the beginning, I'll be talking very briefly about the various perspectives of GDM in relation to the legal implication. So why it is important to discuss and know the medical legal aspect of the GDM? We all know that GDM has become the major health problem. India has become the hub of diabetes.
Just 7:30 start नहीं करेंगे तो होगा नहीं. आपको मैं बता रही हूँ reason और
Indian women are at the 11-fold increased risk of the GDM, and it is the most common medical disorder in pregnancy. The prevalence of GDM has increased from 10 to 14.3% and are bound to increase further up to 20%. And so it is the number of the cases of the GDM is also going to increase. GDM complicates about 4 million of the pregnancy annually, and it is also associated with the increased high maternal and fetal complications, along with the long-term consequences to both the mother and newborn. So if any adverse outcome occurs, then it becomes a potential case for litigation. Now the GDM is also the mother of all NCDs for tomorrow, and NCDs are programmed and imprinted during pregnancy. So early diagnosis and proper management of GDM will help us to overcome this NCD pandemic in future. There is no doubt that the litigation cases related to the GDM are increasing, and the various reasons why the GDM cases are prone for litigation are when one fails to diagnose the GDM, not screening in the early pregnancy, fails to interpret the result correctly, thus missing or delaying the diagnosis of GDM, which results further into the complication later in the pregnancy like macrosomia, stillbirth or neonatal hypoglycemia. Even if we diagnose the GDM in time, the other reasons for litigations can be improper management and control of GDM by either the MNT or the pharmacotherapy, and the associated morbidities like preeclampsia and the preterm birth.
हाँ शिल्पी बोलो. मैं तुम्हें आज याद कर रही थी कि तुमने बाद में बताया ही नहीं. 25 का रख दिया मैंने तुम्हारा 25 को.
Dr. Renu or Dr. Nilisha Pandey, please mute yourself and off the video, please.
Failure to provide adequate information and proper counseling about the risk associated with GDM to both the mother and fetus is the most important reason for legal consequences. And equally important is to document the communication and counseling and obtain the informed consent. Also, the documentation of the poor compliance and refusal to the treatment are the good defense against the litigation. Now, the GDM is also associated with the increased maternal and fetal morbidities and mortalities. And even the postmortem follow-up, where if you fails to provide the adequate postpartum care, with regard to the screening for diabetes in the mother can also result in the medical legal action. So we say that the negligence is the issue in the case of the GDM when one fails to adhere to the standard clinical guidelines and breach of duty of care. Successful litigation is only by when the healthcare provider action causes the harm which could have been prevented with the proper care. Now, we all know that the maternal and the fetal morbidity and mortalities are increased in cases of the GDM, and everyone here in this August gathering must be knowing all these maternal, fetal, and neonates complications. In the case of the fetus, the stillbirth has increased 4 times, and there is an increased congenital malformation, chances of shoulder dystocia ending into the Erb's palsy and multiple birth injury are the potential causes for the litigation. Now, there are number of challenges in GDM due to the confusion and controversy related to the definition, screening, diagnosis and treatment. And it is mainly the screening and the diagnosis which is more important, and this all is because of the lack of uniformity and strict guideline by the various bodies and societies. Also, there is a continuous ongoing studies, research and criteria for early detection and treatment, focusing on the fetus for future to prevent the maternal and fetal complication in current pregnancy. Now, there are the hyperglycemia in pregnancy is given various terminology in pregnancy, and it includes either the pre-gestational, gestational diabetes, early glucose intolerance, overt diabetes type 1 and 2. Similarly, the screening method, whether it should be the universal or selective, 1-step or 2-step cutoff values to control the diabetes or GDM, frequency of the screening and by which method to control the diabetes, by pharmacological method or by with the insulin or the oral hypoglycemic agent as the first line of the treatment are the various challenges in GDM and varies as per the organization and the societies. Now, this we all know, and the hyperglycemia in the diabetes in pregnancy or the pre-gestational diabetes or over diabetes type 1 and 2 will be when the fasting blood sugar is more than 126, random or the 2-hour post glucose load is more than 200 milligram. And GDM will be diagnosed when the 2-hour post glucose load is between 140 to 190. And gestational diabetes is any degree of impaired tolerance of variable severity with onset of first recognized during pregnancy. Usually it is detected in the second trimester. And there is a subclassification of GDM, A1 GDM where it is diet control and A2 GDM where it is a pharmacological treatment is needed. So one has to be very clear in mind about the differences between the diabetes type 1 and 2 and GDM, as GDM is the mild hypoglycemia, while diabetes is very severe insulin resistance with so many complications. Diagnosis of the diabetes in pregnancy now there is also it is associated that gestational glucose intolerance where the blood sugar is 2-hour blood sugar is between 120 to 140 milligram is also equally associated with the adverse maternal and fetal outcome and chances of developing diabetes type 2 later in the night. So now there is a, as per the DIPSI 2023 and which is endorsed by the various organizations like the Ministry of Health, Family Welfare, FOPSI, API and WHO and FIGO, there is a more focus on the early gestational glucose intolerance where at 8 to 12 weeks, the 2-hour blood glucose, if it is more than 110 milligrams, will still lead to the adverse maternal and fetal outcome. And whatever I have discussed, there is still no uniformity with the cutoff in the screening and diagnosis, which makes gestational diabetes more confusing and controversial. But finally, these are the various organizations which are having the different diagnostic threshold for the GDM, and everyone is well aware, knows about all this. So finally, the screening for GDM in India is, according to the consensus, GDM is diagnosed by the universal screening as per DIPSI, National Guideline for the Diagnosis of GDM. It should be the one-step glucose challenge test, irrespective to the meal by 2 hours, providing 2 hours after the 75 gram glucose, and the frequency of the screening should be at the first visit whenever the patient comes, where you can still diagnose 40% of the cases, and again at 24 to 20 weeks. And in cases of the high risk factor, or now it is universally accepted that one should do the screening for the GDM even at the third trimester, which can pick up the GDM in 18 to 20% cases. Regarding the role of the hemoglobin A1C, it is only in the first trimester where it differentiates and picks up the diabetes or diabetes in pregnancy, and it is associated with the risk of the congenital malformation and gives you a chance to do the counseling in the early pregnancy. And these are the various high risk factors, and one has to be very vigilant. The treating obstetrician has to be very vigilant and aware about these GDM associated with these high risk factors. And out of all these, the main three, that is the age above 25 years, in the BMI more than 25, and the family history of the diabetes, are the most three important high risk factors where the obstetrician has to be very vigilant to screen for diabetes, GDM, and irrespectively in all the 3 trimesters. Because in presence of these risk factors, the chances of GDM is always there. And there is always a possibility of legal suit if the diagnosis is missed or delayed, resulting into the harms which could be avoided by practicing the standard protocol and the guideline. So now, to start the panel discussion and to make it more interactive, I request the panelists to give their views based on their vast experience in managing these cases and how to avoid the litigation. And at the end of each case, the final remarks and the right management of the case will be given by our medical legal expert, Dr. Sharma, and the summarizing will be done by Dr. Sangeeta. So to start with the case 1, a Gravida 2, Para 1, Leave 1, with 5 feet 3 inch feet height, and the history of the first vaginal spontaneous delivery with the baby weight of 4 kg. In the current pregnancy, she had regular ANC. Screening for GDM was done 2 times, but in third trimester, there was a mild GDM was diagnosed, which was controlled on the MNT. And clinically, the baby was looking around 4 kilo, and ultrasound has also reported about the weight of the fetus about 4.2. She went into the spontaneous labor at term and progressed well, but ended up into the shoulder dystocia, where all these macroverts and suprapubic methods failed. Posterior arm was delivered, followed by the delivery, but the baby weight turned out to be 4.8 kilo. Baby had Erb's palsy, which recovered in the 2-3 months completely. So my first question is to Dr. Surekha, how to deal such situation and counsel the patient and relative once we come to know the baby has suffered from the Erb's palsy. And the next question will be what is the role of neonatologist as defense in such scenario? Dr. Surekha, please.
Okay, so I'm coming in. I'll take the case. So in this particular situation, we need to counsel the relatives that because the patient was a diabetic patient, she has got 2 to 4-fold increased risk of shoulder dystocia. The second important point is most babies who weigh more than 4.5 kgs do not have shoulder dystocia. And on the other hand, because she was a diabetic, she had shoulder dystocia. And in shoulder dystocia, about around 5 to 16% patients do have Erb's palsy. But the good thing about it is that most of them actually recover. So she needs to be counseled about all this. And regarding the neonatologist defense, the neonatologist should see this baby as early as possible because it is the early, whatever thing can be done as early as possible, like physiotherapy in the first 5 days, it leads to the recovery, complete recovery of the child. And the neonatologist should mention about any other injuries, the Apgar score, whether the baby is going to the NICU, and which shoulder was involved. If it was a posterior shoulder involved, and that means the anterior shoulder was impacted, so probably shoulder dystocia was not the cause. And in about 48% of cases, Erb's palsy occurs without shoulder dystocia. So it's very, very difficult to predict which cases will have shoulder dystocia and which cases will land up with Erb's palsy.
So, Doctor, can we have the comment from Dr. Geetendra?
Can I add something, Dr. Raj, please?
Yeah, most welcome.
So what I want to say is that this patient has gave birth to a 4-kilo baby in the last pregnancy. And this should alert us. We should have our antennas up. And right now also the ultrasound shows that the baby's weight is 4.2 kilos. And again, it is plus minus 10% to 20% in fact. So it could go up. We have to tell the patient at this point of time, when we have the ultrasound report in front of us, we've done a clinical examination, we have the history, which is 4 kilos and positive. She's mild GDM, and we tell her that whether she would like to have a spontaneous delivery, vaginal delivery, which could also lead to shoulder dystocia. And during that time, we are not able to do much. Sometimes, of course, we'll do all the maneuvers, but it's still so-and-so things can happen, which has actually happened. Otherwise, we can also take the patient for a cesarean. So this counseling should be done, and the patient should agree to a certain amount of risk, which will happen during the normal delivery, and she should sign that consent. Okay, we understand this, and we are ready to take this much risk. Over to you, Dr. Raj.
So
I will also second what Dr. Divya has said. It was, she was very, very lucky that she got away with her problems in the first pregnancy. But in this particular pregnancy, the fact that she was gestational diabetes, the assessment of the clinically the weight was more, and the ultrasound also showed 4.2. She should have been taken electively for cesarean section. And in case if she was refusing, all the things should have been there, that the counseling had been done. She was told that there can be chances of having a problem with the baby, and a whole lot of birth injuries can occur as a result of the weight. So I think, if this is counseled, and a negative consent should be taken from her that she was not willing for cesarean section. So in case if this particular case comes to me in NMC, people like us will not allow her to have a vaginal delivery. This is what I feel about it.
So I can just say that there is a role of counseling when the diagnosis of GDM was done in the 3rd trimester. The importance of the counseling comes there, and the role of the documenting your counseling. That's very important than giving the option what she will prefer. And the other thing is that the shoulder dystocia can occur in a low birth weight baby also, in the average birth weight baby also. That also everything has to be counseled and documented to the patient. And regarding the role of the neonatologist, they should also speak the same language. Yes, this is not the result of any negligence by the obstetrician, because these are bound to occur. And as a defense, we can show our literature. The reference to the literature can be given to the patient. Yes, this is it's a natural phenomena where the shoulder dystocia can happen.
Dr. Raj, one
Dr.
small
Anita has
thing.
just now said, Dr. Anita has just now said, even in cesarean section,
Yeah.
if you're doing a large weight baby, there can be a problem.
Yeah.
I think, one should really know how to manage such cases. So your novice cannot be doing a cesarean section who's a good weight baby. And I think, this particular part should be told.
Yeah.
And can I add some?
Any time when there is a diabetes and the shoulder dystocia occurs, whether it is anterior shoulder or posterior shoulder, it is taken as a part and parcel of it.
Dr.
You cannot,
Raj,
Can
yes.
I add something?
yeah, was a case actually filed in this case?
No.
It almost seems as if, they have accepted it and patient recovered the baby.
Yeah, it is
Because the recovery
how you
was complete.
counsel the patient. How you counsel the patient, it makes a lot of difference.
Yeah, and
Okay.
can I add one thing? Actually,
Yeah.
literature also shows that this brachial palsy doesn't occur due to axial traction of the obstetrician. It is also due to the propulsive force of the uterus in the second stage. So it is not always the obstetrician who's guilty or who is.
Yeah.
So that also has to be explained to the patient, that it is not always the axial traction given by the obstetrician which has caused this brachial palsy. It is also due to the propulsive force because the mother tries to push a lot. And that is one of the reasons of brachial palsy.
And
Can I add something?
yeah, sure.
Okay. So one more thing in the clinical management, when you are looking clinically at a weight of about 4 kg and an estimated weight on ultrasound of about 4.2, and she's only on MNT, this probably becomes one of the indications to have a stricter sugar control, despite the fact that diet is doing well. But this could be one of the conditions wherein we would need to step up the sugar surveillance a little more. And in some situations, adding up insulin becomes one of the indications here if she's going towards macrosomia.
I think you are 100% correct. When you're monitoring clinically, and not only she requires insulin, she requires a great monitoring as far as weight is concerned.
Dr. Geetendra. Dr. Geetendra, please now. Sir.
His comments are most valuable. When I was going through this shoulder dystocia, there was ultrasonically, they are saying that this should be also considered apart from the expected birth weight, that is the abdominal diameter was upon the biparietal diameter. If it is more than 26 millimeter, then you can suspect that she may end up into the shoulder dystocia.
And another parameter is actually the bisacromial diameter, and you take the body fat thickness. So those two parameters are also an indication that you might land up in a problem.
But I don't think anyone is routinely doing it.
So maybe we can ask them electively when we see a 4.2 kg
second baby is always more than the first, so we should have
Yes.
suspected this. Yeah.
And whenever we ask our ultrasonologist to measure the bisacromial diameter when the weight is more than 4 kilograms, they usually provide us that diameter.
So I think it needs us to ask for it.
They do.
The obstetrician should write it to comment on the acromial diameter versus upon the shoulder
shoulder fat, the shoulder fat
the
thickness.
ratio between them.
Discussing all this in the birth plan, I think that would have probably prevented this problem.
And she was lucky, the treating obstetrician was lucky, the recovery was complete.
So I think Dr. Geetendra is
Not here. I think go ahead with the second case.
I would like to summarize this case now that as far as this case is concerned, that proper history is very important. If there is a history of macrosomic baby or good size baby in previous delivery, we have to be alarmed. As Dr. Really said, that our antennas have to be up, and we have to consider proper screening, proper diagnosis. And as Dr. Nidhi emphasized, that if we are finding macrosomia in such cases, we have to see whether our sugar controls and the management for sugar control is appropriate or not.
Ma'am, this is the same case is continued where I'm asking the to the Dr. Suman, please, whether the lawsuit can still be a possibility if the recovery is complete. Can the patient still, because she has to undergo 3-4 months of the treatment?
Yes, the possibility of a lawsuit being filed is definitely there. Even if the child has recovered, it can be filed against the doctor as well as the hospital. They can seek compensation for the treatment of the child. They can seek compensation for the loss of wages to the parents. And they can also seek compensation for the pain and suffering the family has endured.
So if they file the case, then how you are going to defend the case?
So in this case, how I will defend this case as because she was a second gravida, she has already delivered 4 kg baby with the spontaneous vaginal delivery, weighing 4 kgs, and the GDM was mild in this case, and it was controlled with medical nutrition therapy, and the ultrasound showed a weight of 4.2 kg. She had a spontaneous labor, and the labor was progressing well. So I was hopeful for an uncomplicated delivery, just like the previous one. But it was my bad luck that the baby turned out to be healthier than the expected, and it was 4.8 kgs when it was delivered. And the baby had Erb's palsy because of the shoulder dystocia. But the good point was that there was a complete recovery within 3 months.
The other defending points will be you have to note down and document the
everything has to be documented during the antenatal period. Maybe
the counseling part and the documenting the every single
telling her about everything
how you
about
are delivering the
shoulder dystocia and the
how you
possibility
have
of an elective cesarean section, which she might have refused, saying that she has delivered a 4 kg baby in the first.
And it should be step by step, the call for the help and everything has to be documented properly. And now the next question is, suppose the recovery is not complete, then in this case you are lucky, the patient was lucky.
They recovered. But if the recovery is not complete, then they have to face the consequences. I don't know. Dr. Geetendra will be.
Dr. Geetendra is here. Dr. Geetendra.
Madam, complication per se does not mean that you are negligent. So if you have done all counseling properly, if you have documented everything properly, if you have followed the standard guidelines and not diverted from the standard guidelines, then even if Erb's palsy will occur, it is not considered as a negligence on the part of doctor. So in cases which are fought in the court of law, the decision comes how you have represented your case in the court of law. So if you will represent your case properly in the court of law, then definitely there are good chances of winning the case.
Dr. Geetendra, can I ask one question?
Yes, madam.
So is there any liability of the ultrasonologist? Because the report was grossly wrong.
Madam, in all the machines, plus minus 10% is possible.
Yeah, but this is more than 10%.
It is 20%.
Yeah.
The birth weight, regarding the birth weight.
And even 10% is the normal variation which is there. So in diabetic patient, nobody can guarantee you that what is the exact weight. And particularly in big baby, to predict the exact weight is not easy. So we cannot hold ultrasonologist as a liable person. And moreover, more about that only weight is not the cause of shoulder dystocia.
And Dr. Jhanna, what is the maximum period for filing the case?
It's 3 years from the birth of the child or 3 years from the diagnosis that has been made.
Cause of action.
Yeah.
So in this case.
I think this is totally wrong. Now, as far as law of this way things are going on, anytime jab wo jag gaye or jab unhone dal diya, to people will accept it, whether it's NMC or whether any state council. Ye wala jo criteria, it is going absolutely fuss.
No, madam, aisa nahi hai. Basically, in Consumer Protection Act, it is clearly mentioned that no case can be filed after passage of 2 years from the cause of action. And multiple cases are being quashed, which are filed by the patient after this period of 2 years. So in most of the cases where patient files case after 2 years, we take this type of objection. And in 95% of the cases, this objection is considered as valid objection. unless patient is able to prove in the court of law that patient was suffering with some incidences or some reasonable cause was there which prevented them to file the case. So multiple cases are being caused which are filed by the patient late after 2 years of the passage of.
Doctor, in consumer protection, maybe I say, but as far as my experience of the last almost 25 years shows that, bilkul dabe hue cases, they come up and, the councils, give them the law, justice.
Madam, 3 months back only, one doctor from Dwarka, one Sikh doctor, Dr. ACP. So we fought his case, and this consumer court did not allow to file the case to the patient.
Madam is saying that in NMC and DMC, what is the situation?
In
DMC, they will entertain. This clause is there. But Madam, once they are counting against the state council, NMC accepts.
Madam, in NMC, if you go to the MCI Code of Conduct regulation, whatever it is 2002 regulation is there. In that, there is no limit, no time limit given to file a complaint against doctor, and that's why they are entertaining. But in Consumer Protection Act, the limitation time is clearly mentioned. That is 2 years from the cause of action. So if something has been diagnosed, from that diagnosis to 2 years, if it is passed and no reasonable reason has been given by the relative of the patient, then they will never be allowed to file the case. Although there are examples where even after 11 years, the cases are being allowed to be filed against doctor. But in those cases, the relatives were able to prove in the court of law that there were reasonable reason why they have not filed the case in last 9 years.
Dr. Ela has got some query. Yes, Dr. Ela?
Yeah, I have I just want to share one of my case because everyone is talking about 4.2, 4.8 kg of baby weight. I had a patient, Primey, who had weight in ultrasonography was 2.9 kg. After 3 weeks, she delivered. Like ultrasound ke 3 hafte baad she had a vaginal delivery. But when the baby came out, again, she had a shoulder dystocia and we delivered somehow. Baby was all right. Everything was fine. Then next day morning, I saw that they told that baby ka hand thoda sa problem hai. Then I got to know that she has developed this thing. So I told pediatrician, they diagnosed it, and then the patient wrote something bad about me in the Google. But I just wanted to know and sharing this thing that the baby weight came out was 3.8 kg. Wow. And it was 2.9 kg in the ultrasound. So even in spite of all that, and actually I was, the last moment I was taking her for cesarean, patient insisted that nahi madam aap forceps laga do and all that. So, लेकिन उससे कोई फायदा नहीं, बिकॉज हमने कोई डॉक्यूमेंट तो की नहीं है पेशेंट की बात की भाई आप पेशेंट ने इंसिस्ट किया है या क्या है. तो हालांकि अभी तक उसका कोई आया नहीं है, लेकिन स्टिल आई वांटेड टू नो कि हाउ आई एम प्लेस्ड इन दिस काइंड ऑफ सिचुएशन. सर बता दें.
अगर सोनोलॉजिस्ट ने ग्रॉस नेग्लिजेंस की है, मतलब अगर 3.5 kg का बच्चा और वो 2.5 या 2 kg लिख रहा है, तो डेफिनेटली he also can be sued and he will be he has to prove himself in the court of law that why this kind of variation in weight is there. So
सर लेकिन 3 हफ्ते बाद हुआ है, 3 हफ्ते में तो बेबी का वेट वो हो जाएगा.
3 हफ्ते वो उसके लिए वो एक्सक्यूज है कि 3 हफ्ते में बेबी 1 किलो वेट गेन कर सकता है.
हाँ 1 किलो कर सकता है वेट गेन. 200 ग्राम्स पर वीक के हिसाब से भी देखें तो थोड़ा सा मतलब
तो प्लस माइनस 20-10.
डॉक्टर इला एक बात बिल्कुल क्लियर है, नो डॉक्यूमेंटेशन नो डिफेंस. अगर आपने कुछ लिखा नहीं है, कुछ काउंसलिंग नहीं करी है डॉक्टर, और उसका कोई रिटन डॉक्यूमेंटेड प्रूफ नहीं है, यू कांट सेव योरसेल्फ.
मैम इसमें काउंसलिंग क्या करते, क्योंकि जब स्टक हो गया वो तो हमें अंदाजा भी नहीं था कि वो, क्योंकि 2.9 kg का था, देखने में भी बहुत बड़ा नहीं लग रहा था. बट व्हेन इट केम आउट इट वाज 3.8 kg. एंड देयर वाज अ स्लाइट, हमने पेशेंट को बता दिया था कि बहुत मुश्किल से डिलीवर हुआ है, हमने खींचतान के निकाला, ये सब बताया था, लिखा भी है केस शीट में. लेकिन पेशेंट जब कह रही थी कि फॉर्सेप्स लगा दो, उसको हमने डॉक्यूमेंट नहीं किया.
Consent and everything. So here comes the importance of all.
re-emphasized.
And then you have to write in document the step-by-step delivery.
Yes.
That is
And
important.
actually, I just wanted to know, डॉक्टर राज, आप ये बताओ कि जो जैसे आपने उसको शोल्डर डिस्टोशिया टैकल किया है, तो उसमें नोट्स किस तरह से डालने हैं? दैट इज द मोस्ट इम्पोर्टेंट पॉइंट व्हिच वी शुड लर्न.
Yeah, actually there is a form which you can fill it up and it shows a checklist. तो उसमें पहले चीज ये लिखा होता है कि what is the time when the baby was delivered and who had taken the delivery, that has to be written, and what is the time you called for help and who else had come at the time, who were present at the time of delivery of head and who had assisted at the time of delivery of shoulder. And then subsequently you have to write what was the presentation of the baby when it presented with shoulder dystocia, whether it was a spontaneous delivery of the head or a forceps application. There are checklists, we have to complete that. Then all the maneuvers have to be written, then the maternal examination, whether there have been tears or not, and then the neonatologists who have examined the baby, whether there have been breakage, whether there was any weakness in the arm, everything is checklist, or there was any injuries, or whether the baby went to NICU. All this checklist has to be completed and attached to the form, attached to the case sheet.
बट उसमें ये भी लिखना होगा ना कि इसको शोल्डर डिस्टोशिया हुआ, हमने कौन सा प्रोसीजर किया, कैसे निकाला, कितना.
All the maneuvers have to be written step by step. Macropods, episiotomy, posterior arm, everything has to be written step by step and ticked.
Okay.
And the time from the delivery of head to the complete delivery of the baby has to be mentioned.
Has to be written, yes.
Yeah.
So the warning signs of the shoulder dystocia is shown here. There will be a slow progress in the first and second stage of labor, head bobbing sign, head coming down during the active pushing and then receding in between the contraction, total sign. So one has to think about and predict it. Okay, yes, she can adapt into the shoulder dystocia, and then that is still the time you can take her up for the cesarean, or you can counsel her, take the negative consent. All these, I think these are important.
Madam, it is not desired rather to write all these signs and all these maneuver.
No, this is just to know yourself.
Yeah.
Yes, if the
To anticipate. This is just to anticipate. Yeah.
You can anticipate that she may end up into the shoulder dystocia. So rather than trying the forceful delivery, the forceps and going through all these, the increased risk of Erb's palsy.
हाँ, अगर ये hobnob sign है कि आ रहा है जा रहा है, तो we should not apply ventilus or forceps.
Yeah, that's what I'm saying. And this is the landmark case.
So basically what I want to convey is that there may be multiple schools of thoughts, multiple kind of techniques to deliver the shoulder dystocia may have been mentioned in different books. So if you follow any one of them, you are not negligent.
So Dr. Raj, this says in the end implications, the ruling made it clear that doctors must ensure patients are aware of all the risks and alternatives, and they should engage in a meaningful conversation. Does that mean that we also tell them that if you are going to try for a normal delivery for you, but there could be a possibility of doing forceps or a vacuum? So do we take the consent for forceps and vacuum now while discussing all this with the patient much before she's gone into labor? And do we also tell her why we may have to do cesarean? All those kind of things which we face for eventually.
So can I answer that?
Okay, yeah.
Yeah. Dr. Divya, I was also going to ask the same thing, because we have now changed over to the new FOXY uniform consent for vaginal delivery. And we have started, using that, because we are not taking it for granted that the patient is to be informed beforehand about the possibility that a vacuum/forceps may be required. Because that is, like Dr. Ila correctly mentioned, that is not the time when you can even take a consent. Patient is in pain, she's in second stage.
That will not be a valid consent.
Yes, and that will not be a valid consent because she's in pain. So when we discuss a birth plan, which may be 35, 36 weeks, and when the patient, the date is approaching and we start discussing, I found that this FOXY uniform consent, which is available to all of us on the site, if we incorporate it in our own hospital practice, I think we will be in a very better position to be able to, make these decisions and, to say that we have informed her. Like if you see this landmark case, her claim was that they failed to inform her of the risks and alternatives to vaginal delivery. You know the kind of pressure that we all as obstetricians face with the patients wanting a vaginal delivery. So I think now the time has come that we should very clearly tell them, including complete perineal tear, lacerations, cervical tears, you know, and even stress incontinence.
Madam, I beg pardon that my opinion is absolutely different. See, for vaginal delivery, there cannot be a consent. See, we cannot understand, basically, we do not understand what is the difference between counseling and consent. For vaginal delivery, you can counsel the patient. Whatever you want to inform the patient, you can inform. But that is not a consent. Consent is for a specific procedure we are taking. So, even after taking consent, can you stop vaginal delivery? Answer is no. It is a spontaneous procedure. So for spontaneous procedure which is not in your hand, how can you take consent for doing vaginal delivery and not doing vaginal delivery? So the concept of taking consent of vaginal delivery itself is absolutely wrong. I do not agree with that. See, you can counsel. Counseling can be done. You can inform patient the risk of vaginal delivery. That is known as counseling. That is not a consent. So consent cannot be taken for vaginal delivery.
So this can be a consent for safe delivery, whether vaginal or cesarean.
And second thing, we cannot take advance consent, advance blanket consent for this ventus or for the forceps application or for cesarean section. See, in many of the hospitals, they are taking blanket consents. At the time of admission, they are taking LSCS consent. So, see, basically consent has 6 parts. And the first part is indication. So when indication of some procedure is not there, not existing, at that time you cannot take consent. That consent will become invalid.
I think I 100% agree with what Dr. Geetendra is saying, that it is only counseling and cannot be consent.
So Dr. Geetendra,
we must understand the difference between what is counseling and what is consent. Counseling is that proving that we have informed this much to the patient and we have communicated, and that is the difference in between valid consent and informed consent. See, in America, people follow informed consent. In informed consent, it is a one-way consent, one-way information given from the doctor to the patient, and patient goes through the literature which is provided to the, so doctor has to prove in the court of law that I had provided this much information to the patient. And after getting this information, patient has come for the treatment. There is no signature of doctor and patient both and in presence of witness in informed consent. While in India, we are supposed to follow valid consent. In valid consent, the consent is considered as a valid contract in between doctor and patient, and which is signed by 2 witnesses. So if you go through the valid consent, then it become a consent in perspective of the decision given by the Supreme Court in India in case of Samira Kohli versus Dr. Prabha Panchadda. So I agree with that the counseling should be done. Antenatal counseling sessions should be done. We have to inform the patient the consequences of normal vaginal delivery also, consequences of different kind of procedures also, unexpected complications which can happen to the patient. These all types of antenatal counseling can be done. You can do antenatal counseling session with the patient and inform whatever you want to do. But that does not mean that it is a consent of vaginal delivery. There cannot be a consent of vaginal delivery.
One question I just want to ask regarding this forceps and ventus. Are we supposed to take a verbal consent or is it a written consent? Because most countries have verbal consent. We have counseled them.
Now we will talk this
Madam,
on this point
verbal,
the next day.
Consent, it is mentioned in Samira Kohli's judgment that consent can be implied consent, it can be oral or verbal consent, it can be written consent. Now, why we pressurize or guide that it should be a written consent? Because it is not easy to prove in the court of law that implied consent was there or oral consent was there. So it is very difficult to prove in the court of law that oral consent was given. And patient usually later on will say that I had not given the consent. So it is very difficult to prove the oral consent in the court of law, and that's why we prefer that written consent should be taken.
So then what is the solution when you say that the consent is not valid when patient is in pain? Then what sort of consent we should take at that time then?
So, madam, if possible, see, in second trimester, this second stage of labor or even in first stage of labor, it is not considered that patient consent is not valid. So, a patient is completely conscious.
Yes, yeah.
Only in pain, it doesn't mean that consent is not a valid consent. So,
But sir, the plea that is often taken when the patient gives consent in second stage is that she was in pain. And one of the criteria is that she should be in a sound frame of mind.
Yes.
So the opposing side usually takes the plea that she was not in the sound frame of mind and therefore it is not a valid consent. How do we defend that?
Yeah. So basically, only one thing is mentioned in the Supreme Court judgment, that there are two circumstances when information may not be passed on to the patient. So that is that one, that information, if you are 100% sure that if you will pass on that information to the patient and if you will take consent, it will harm the patient. So in that case, you may not take consent. And second, in emergency, where the question of life and death is there. Now, in pain, if patient gives consent, it is a valid consent.
But if not,
nobody can say later on that I was in pain and this consent may not be considered a valid consent. When patient gives the consent and signs some paper, it will be presumed by the court of law that she has understood and signed. She cannot say that I was in pain. So if you are in pain, why you had signed the paper? You would have denied signing the paper. So basically, these kind of excuses are not valid in the court of law. If somebody signs the case paper, even in pain,
even if we take the consent in the second stage of labor, then it will be a valid consent.
yes, only judgment says that when patient is under anesthesia.
Cesarean का भी तो तभी लेते हो ना?
Patient is in labor, we are taking a consent for emergency cesarean. तभी तो patient labor में है.
Labor में
As far as I am concerned, I feel, as far as I'm concerned, we definitely counsel and take a consent for a delivery, but delivery is a retrospective phenomenon. We said in case of cesareans required, consent will be taken from you. But for forceps or for ventus, no consent will be taken from you.
No, but in instrumental delivery, madam, consent is must. So if you are doing forceps delivery or see in emergency when patient is in last stage of labor and bearing down, and at that time when patient is not in position to give consent, definitely that consent is not required. But if it is patient is in second stage of labor and in position to give the consent or understand the consequences, then you must take consent of instrumental deliveries. Ventus and forceps delivery, you must take consent because it is a procedure done by you. But in vaginal delivery, you cannot stop vaginal delivery. So vaginal delivery, we don't recommend consent for vaginal delivery.
सर एक बात और बताइए कि जैसे हमने इमरजेंसी वो सेकंड स्टेज में फीटल डिस्ट्रेस हुआ, इंस्ट्रूमेंटल डिलीवरी की, शी इज नॉट इन अ स्टेट ऑफ माइंड टू गिव द कंसेंट, वी अप्लाई द फॉर्सेप्स, द बेबी हैज टेक द consent later on. Yes, we have told you now you sign it, because some institutions they are doing like this.
Madam, if you have done something to save the life of the patient or child in emergency, then no consent is required at all.
No.
That is the law.
Thank you so much. So we move further. Dr. Sangeeta.
I think Dr. Geetendra is going to explain about this case, which is the leading case, and we need to know about this case each and every time. Whenever we talk about informed case, it was a case of shoulder dystocia which was happened, and Dr. Geetendra, I need 5 lines from you summarizing this case.
Can we have the last slide, the previous one, about the case? Yeah, this
Yes.
one, yeah.
This one?
No, the
Montgomery.
case.
Sir, your final 5.
Madam, one thing I have already mentioned, that informing patient about the risks is our duty. So even if patient is delivering vaginally, during antenatal counseling session, you must counsel the patient that what unexpected complication may happen, which may include shoulder dystocia, which may include PPH, which may include other complications, even uterine inversion. I can say that it can happen. So all unexpected complications should be informed to the patient, which can happen in advance during antenatal counseling session, and document it that you have informed, so that patient cannot say that I had not been informed. Even if some complication which are rare most not informed to the patient, later on patient may not tell you in the court of law that this was not informed. For example, uterine inversion, which is a rarest complication. So in the judgment of Samira Kohli versus Dr. Prabha Manchanda, it is clearly mentioned that how much complications are to be explained, and in which it is clearly mentioned that you should not explain the risk of a procedure in such a way that patient will become ready for a fanciful surgery which is not required at all. So you cannot make patient fear of delivery, vaginal delivery. Okay. So if rare complications are not being explained to the patient, you may not be held negligent in the court of law. So in court of law, going through only some judgment, we cannot say that some doctor did not inform and that's why this judgment came against doctor. See, the reason of judgment coming against doctor are different, because one, in 95% of the cases where the judgment goes against doctor, the reason is poor documentation. They don't document properly, and they start taking excuses in the court of law that we had informed. When you have not documented what was informed, you cannot take that advantage. And second thing, rest 5% of the cases which are not been which have gone against doctor, the reason is poor representation. You don't go to court, you don't see what your lawyer is explaining, who has no medical knowledge. So if your lawyer do not explain properly in the court of law, then decision is going to be against you. So basically we always tell that lawyer do not understand the medical language, your senior doctors do not understand the legal language, and that's why whenever you want to defend yourself, always take help of a proper medico-legal person so that he can defend you, he can guide you in a proper way. So that is the difference. See, the same case which has gone against doctor was gone in favor of doctor in appeal when represented properly. I always give one example. One doctor did hysteroscopy, patient died on table due to pulmonary embolism. Now in that case, 5 questions were asked which were answered by a lawyer. First question was, sir, what you were doing? The answer was hysteroscopy. Second, what happened? Why patient died? He said that the patient died of pulmonary embolism. The third question came that, is it a known complication? The answer given by the lawyer, which was feeded by the gynecologist, that, sir, yes, this is the standard textbook in which it is mentioned that one of the risk of this hysteroscopy is pulmonary embolism. So it is a known complication. The fourth question, then what is the treatment? So he said that patient is to be kept on ventilator because positive pressure ventilation is to be given. The fifth question came, did you keep ventilator ready before starting hysteroscopy? The answer was no, and the judgment was immediately given against doctor. 3 lakhs rupees compensation was granted in 2001, saying that you didn't keep ventilator ready while doing hysteroscopy. Now this judgment came only because of poor representation by the lawyer, although he was the senior most lawyer of Bangalore. He was one of the dean of National School of Law. He lost the case. But when we came in defense, in appeal, we answered it in a different way. The first question What you were doing? Answer was hysteroscopy. Second, why patient died? Patient died of pulmonary embolism. The third question came, is it a known complication? Answer was, yes, it is a known complication, but it is a very rare complication. In every delivery, there are chances of amniotic fluid embolism. That doesn't mean that we cannot deliver a patient without keeping ventilator ready. So when you answer in this way, the judgment differs. Second, that there are nowadays hysteroscopes are available, which office hysteroscopy can be done without having anesthesia. So we cannot be expected, nobody can expect from our side that we should do hysteroscopy. We cannot do hysteroscopy without keeping ventilator ready. So if you represent your case in this way, the judgment will definitely come in your favor. So same way in shoulder dystocia, as discussed by all of you, if you will put forward multiple things that we have applied all the maneuvers, proper counseling was done, proper documentation is done, you have applied all the maneuvers. So if you have done your level best, then you cannot be held negligent. And if you present your case properly. So everybody is asking one case, that in one case, National Commission gave the judgment that Robertson method was not applied, and that's why doctor was held negligent. See, no court can hold doctor only for not writing in the document that Robertson maneuver was applied. It is not necessary that all maneuvers are to be applied or to deliver the shoulder dystocia. And not applying a particular maneuver cannot be the cause of Erb's palsy, as mentioned by Sharma madam. There are multiple other reasons of Erb's palsy.
I think very true.
So basically, the judgment only comes how you represent. And that is the important thing to learn. Law cannot teach doctor medicine. What is to be done is to be decided by doctor according to the standard guidelines given in the different textbooks. So something which is mentioned in, suppose in India, in one textbook or in one guideline issued by a big association, that you should not deliver 4 kg baby, more than 4 kg baby vaginally. If that kind of guidelines are being provided by some of the associations, and if you deliver or try to deliver 4.2 kg baby vaginally without taking proper consent or without explaining to the patient the risk of delivering 4.2 kg baby vaginally, then you can be held negligent. So you have to follow the standard guidelines. And what is standard guideline is decided by the court of law by applying 4 questions, 4 ways. First, something what is written in your textbook. So Indian textbook will be given the first preference. Then foreign textbooks. Then something which is written in index journals. Not foreign guidelines, but Indian text journals. And second, then foreign text journals, index journals. Third, what is taught by your teachers in your medical colleges to the students. And something what is practiced by your peer group. So if you follow these 4 guidelines, that is considered a standard guideline. So suppose you get 10 expert opinions in your favor that 4.2 kg baby can be delivered vaginally, then definitely court will consider in favor, consider it in your favor. But see, at the time of explaining yourself in the court of law, if you don't put expert opinions in your favor, if you don't put your defenses in a proper manner, then case is going to be decided against you. Put your defenses properly in the court of law and you will win the case, definitely.
Thank you, sir. Very, very nicely briefed and hit किया sir आपकी सारी बातों ने हम लोगों को किया different points पे. And I think now, Dr. we can move to our case 2. She's a primary caregiver, diagnosed GDM in 3rd term on diet control and IHCP. Expected baby weight is only 3.1 kg. Induction of labor with consent done at 39 weeks. Under continuous fetal monitoring, the labor progressed well, but had fetal distress with immediate recovery in 2nd stage. Vacuum followed by forceps applied but failed. and decision for LSCS, but the patient's relatives wanted to wait and not giving the consent. After more than a half hour, where the consent for LSCS was given and LSCS was done, the procedure was uneventful, but newborn was asphyxiated, and even after resuscitation done by pediatrician, needed ventilator support, and after 8 hours, baby was declared dead. Mother had multiple tears in vagina and traumatic PPH occurred, and blood transfusion was given. So patient and relatives were very aggressive, abused the staff and doctors, and recorded in CCTV. Hospital bill was paid by management. This is a case of Delhi only. And later patient had 2 live births. Patient still filed the case, though now she's having 2 live births, but still patient filed the case. Now the question arises, in this case, is doctor negligent? Dr. Leena?
So I do not agree that the doctor has been negligent. First of all, a correct decision to induce labor was taken, a proper consent was taken, the indication was, gestational diabetes and IHCP, for which, we do an induction of labor. That being so, patient was monitored properly during the labor, unfortunately developed fetal distress, and I am assuming that the indication for applying vacuum was correct, because the only thing is that 2 instrumental deliveries were done, both a vacuum followed by a forceps. But I assume that there must have been some reason. Maybe there was a cap put, and that is the reason why they had to apply a forceps, and that failed. Now we come to where the things went wrong.
Yeah.
While prima facie, it really is very clear that the doctor did everything that what an average or a well-skilled obstetrician would have done in the same place. Where the things went wrong was there was a delay in giving the consent. The time of giving the, when there was a delay, like they were not giving the consent, that should have been mentioned. And a negative consent should have been taken to document that half an hour delay, which is very crucial after an instrumental delivery has been done, which has not resulted in a delivery of the baby, and the fetal distress had progressed beyond that period of time. And that was one thing which went wrong. The subsequent management seems quite, as per the standard guideline. The other thing is when the patient's relatives became abusive, and all this was recorded, and then they, the hospital bill was paid by the management. I think that was also not correct, because, when bills are paid, it is almost like there is an admission of guilt. It is true that the baby died, but it was not for want of efforts, because all efforts were given by the pediatrician. Baby was put on ventilator, and it was some time later, because of severe perinatal asphyxia, the baby died. So the things that went wrong was the delay in getting the consent from the relatives. I think that was very crucial in this case. Whenever such a thing happens, that they are not giving consent in time, it should be recorded that they are refusing to give consent. Sometimes a signature of refusal of giving consent is not given by the patient or the attendants. In that case, whoever is there with you, there may be other doctors, there may be other staff, they can also give consent. And also, there may be other patients in the labor room whose relatives or attendants may be witness to the entire proceedings. And they can also give consent that, the attendant, and the patient and the attendants are not giving consent for a cesarean section. That will really help us when later the patient files a case, that the negative consent, was not given by the relatives in time, and that can be used as a defense. Video recording is also now, being done in lot of centers, and I think that is now something which will sort of add more value to the fact that attendant did not give consent on time. So I think I have answered that, what to do if not giving refusal consent. that also I have answered.
Thank you, Dr. Leena. Sir, we now need your opinion how to deal with this case, and I think you are going to replace all the mays with should.
Yes.
That means we all what we should really do. May is may. We could have done this, we could have done this, but now we really need what should have been done or what we should do.
So basically, everything has been explained by Madam, but 2-3 things I want to clarify. One, documentation of refusal of consent is okay. It is required. It is going to save you to certain extent. But suppose patient is not ready to give you consent, and patient, you are keeping that patient for 1 hour, 1 long hour without taking consent in your hospital. Why you are keeping that patient in your hospital? What efforts you have done to avoid or to refuse the treatment to the patient if you are not agreeing to the refusal? So only documenting refusal is not going to save you 100%. That is definitely one thing which you should do. But if you feel that a baby is going to die if I am not going to do cesarean in next 1 hour, and if patient is refusing for the treatment, then you should refuse the treatment of that patient, and you should try something, or you should do something to refuse the treatment and to shift that patient from your hospital.
If they refuse to go,
how can you do that?
If they refuse to go,
Sir,
Yes.
it is not easy. They
That
will
is
not
also
leave.
to be refusal of shifting is also to be documented. That's what I want to share with you. And second thing, that even after that, if patient is not ready to be shifted, then at least inform police. It will you will feel that in everything, why to inform police? But
Sir,
this is the way of dealing this.
Sir, in half of the cases, we also want to do a डीला डाली और हमको लगता है कि पेशेंट भी कह रहा है कि मत कराओ, तो हमें लगता है कि ये हमारा एक सपोर्ट हो गया कि हाँ रिलेटिव्स ने भी रिफ्यूज कर दिया.
हाँ, तो 2 घंटे मैडम, अगर आपने 10 बजे सुबह पेशेंट को कहा सिजेरियन करना पड़ेगा, अगर पेशेंट ने कहा नहीं, बोला नहीं आप ट्राई करो नॉर्मल के लिए, एंड इफ यू हैव सकम टू द डिमांड ऑफ द पेशेंट एंड आपने कहा ठीक है 11 बजे तक ट्राई कर लेते हैं, फिर आप कहो कि 11 बजे अगर एस्फिक्सिएटेड चाइल्ड आया तो मेरी कोई रिस्पॉन्सिबिलिटी है, वो आपको एक्सक्यूज नहीं मिलेगा.
सर एक बात बताइए,
यू हैव सकम टू द डिमांड ऑफ द पेशेंट. सो आप पेशेंट की डिमांड को सकम नहीं होना चाहते हैं, तो यू विल हैव टू प्रूव इन द कोर्ट ऑफ लॉ दैट व्हाट एफर्ट्स यू हैव डन टू शिफ्ट द पेशेंट और टू रिफ्यूज द ट्रीटमेंट टू दैट पेशेंट which is not agreeing to your guidelines. तो अगर पेशेंट आपकी बात को नहीं मानता है, तो you should do something to prove in the court of law that पेशेंट ने रिफ्यूज किया तो मैंने ये किया, मैंने उनको दोबारा से ये इन्फॉर्म किया कि भाई ये इमरजेंसी है, इसमें डिले नहीं चलेगा. सेकंड, अगर उसके बाद भी उन्होंने किया तो हमने उनको कहा कि ठीक है फिर हम ये ट्रीटमेंट नहीं कर सकते, यू शुड शिफ्ट योर पेशेंट टू अनदर सेंटर. दैट इज ऑल्सो टू बी डॉक्यूमेंटेड. और फिर भी अगर वो रिफ्यूज करते हैं, हम शिफ्ट भी नहीं करना चाहते हैं, तो देन इन्फॉर्म एटलीस्ट पुलिस ऑन फोन वंस, सो दैट दीज ऑल थिंग्स विल हेल्प यू इन द कोर्ट ऑफ लॉ.
Very harsh steps, but
shifting to another hospital and informing the police. This we are listening for the first time.
Yeah, very harsh steps, but we have to save ourselves, and for
मैडम
that
धीरे-धीरे अभी बहुत कुछ नया सुनोगे.
नहीं सर, नया सुनना ही नहीं, करना भी पड़ेगा. That's why I said that we should do this.
Are not we don't feel that these are practical things. But to protect ourselves, we have to learn.
Yeah, we have to change ourselves from may to should.
And in most of the cases, patient says that मेरे को नहीं कराना है सिजेरियन, या रिलेटिव बोलेंगे, लेकिन आप जब कहोगे साइन दो रिफ्यूजल का, तो they don't agree. So in those cases, हम हमेशा बताते हैं कि if patient and the relatives do not give or are not ready to give you the refusal consent, तो आप उसको एक दूसरे इंडिपेंडेंट 2 विटनेस रखो, जो आपके हॉस्पिटल में दूसरा पेशेंट कोई एडमिट है, उसके रिलेटिव हो या कोई और हो जो आपके स्टाफ वाले ना हो. So in presence of some other doctor, you have to again explain or counsel the relatives of the patient that what is an emergency in this particular case, and both doctors should sign in presence of 2 independent witness, and it should be documented in presence of 2 independent witness, and that will be considered as more valid in absence of sign from the refusal from the
So
relatives.
now we have to do a legal obstetric practice.
Dr. Raj,
एक बात और बताइए सर, because there was a fetal distress, and in case of emergency, if we do the cesarean without the consent, will it be मतलब any legal implication? And suppose
Madam, there is yes.
the cesarean,
So there is one judgment, madam.
explicated.
Yeah, there is one judgment from one of the courts in Kerala, in which it is mentioned that आपको पता था बच्चा मर जाएगा तो आपने सिजेरियन बच्चे को बचाने को क्यों नहीं किया?
That's what is my question.
हाँ, so ऐसा भी judgment है, definitely.
So we can go ahead showing the CTG.
नहीं, but
नहीं, but it is not advisable.
निकालोगे वो नहीं बचेगा तो फिर
It is not advisable.
You cannot put
Without
knife
consent,
on the
avoid.
patient without patient's consent.
नहीं, जैसे अब यदि आपका पीपीएच हो रहा है, पेशेंट कोलैप्स हो रहा है, तो आप खोल सकते हो ना?
वो तो
लाइफ सेविंग हो गया.
That is a life saving hysterectomy. हाँ.
हाँ, तो this is the life saving for the neonate.
नहीं, but हम वहां तक नहीं पहुंचे, अभी मदर पहले आएगी.
So what is your take home, Dr. Geetendra?
तो मदर की लाइफ जब भी endangered हो, you must do.
हाँ, not for the fetus.
Not for the
You
fetus.
cannot wait for the consent. If it is a dire emergency to save the life of mother, but nowhere it is mentioned that to save the life of the fetus you can operate without consent
Correct.
of mother,
So, right,
because you are operating
You are
on the body
cutting
of mother to deliver the fetus.
So I
Dr.
clear
Geetendra, what you just mentioned that, if the patient says like this, you can always tell that you refuse the treatment and you go to another hospital and you can inform the police. Most of the time when such a thing happens, we call, the hospital MOD and, 2-3 other people, they come there and eventually the patient gets convinced. This is what is happening with the majority of us. But like in this particular case, crucial time is lost in that. So how
if
to
you have
justify-
done something in this regard, and while doing this procedure, if time is lost, you cannot be held responsible for that.
Okay.
So I wanted to add something, sir. Sir has given exactly the harshest and the correct steps at such a point of time. But what I feel is that, this is the time when the patient refused or her relatives refused to give consent for the cesarean, which is a very common happening in our practice. That is the time when we have to do a very firm communication. And this starts during the antenatal period. कि अगर आपकी हम नॉर्मल डिलीवरी के लिए पूरा ट्राई करेंगे, अगर 2 घंटे हम आपको देंगे सेकंड स्टेज में, फर्स्ट स्टेज, ऑल दीज थिंग्स आर एक्सप्लेन्ड ड्यूरिंग एंटीनेटल क्लासेस. एंड अगर वो चीज नहीं होगी तो फिर या फिर आपके सीटीजी में आपको ग्राफ ऐसे ऐसे करके दिखेगा, then we will have to do a cesarean बेटा. ऐसे कर करके हम पहले से ही उसको प्राइम करके रखते हैं पेशेंट को. And when the time comes and the patient says कि doctor look my graph is going like this, and look doctor the watch is showing I have already pushed for so many days. So the patient is in a way your friend at that time. You are a friend of the patient. There is no enmity between the two कि उसने ये कहा उसने. So that means that a lot of communication and a lot of guidance and counseling has to be continuously given to the patient, and that is the point of time when we can't say कि अरे बस कोई बात नहीं ट्राई कर लेते, आधा घंटा पेशेंट नहीं रेडी हो रही है, तो we have to be firmly communicative at that time.
Dr. Divya, can I just add? Today itself, I had a case while I was doing a myomectomy. My patient, she had fetal distress. Now, what happens is while the patient and the husband, who's been your patient for 9 months, and you have discussed the birth plan, and what you said absolutely is what we are doing, discussing. Suddenly, in the labor, while they're there, a lot of people appear who were never there in the antenatal period, like the mother-in-law, the father-in-law, some uncles, aunts, who claim to be connected to somebody in the medical line. And it is they who come in and say, Doctor Sahab, thoda aur try kar lete hain, thoda aur dekh lete hain. So in the Indian scenario, just the couple counseling and discussing birth plan actually doesn't work on the ground level when we are faced with situations like this case. So,
Madam, I will add one more thing.
Leena, if you are strict during your antenatal counseling, this is what I tell my patients.
Oh, that is why. That is why, because I'm
safe for both mother and baby.
Yeah.
But if my fetal heart is going down, I will just not wait for a second.
So this is
Immediate
exactly
cesarean.
what happened
Yeah,
because I was
One
in
more
my
thing,
antenatal
we are
counseling.
into
They agreed very
And
quickly.
no mother-in-law, nothing.
Let
Nobody will
Dr.
interfere.
Yeah. They agreed.
You have to tell them.
One by one.
Sir.
मैडम वी आर इनटू ऑब्स्टेटिक ओके एंड वी ऑल नो दैट ऑब्स्टेटिक जो प्रैक्टिस है ना बहुत अनप्रेडिक्टेबल है. आई विल लाइक टू मेंशन वन केस इन गुजरात इन वन ऑफ द सिटी नोन एज मोडासा. One patient landed in one hospital at 5 a.m. in the morning, and patient was having moderately thick meconium. So doctor advised that patient that this is a case of fetal distress, thin to thick meconium is there, so I will advise that you should undergo cesarean section. Okay, now patient didn't agree and they went to another hospital. वहां 6 बजे दूसरे गायनेकोलॉजिस्ट के पास पहुंचा. दूसरे गायनेकोलॉजिस्ट ने भी देखा थिक मेकोनियम है. शी ऑल्सो एडवाइज्ड पेशेंट टू गो फॉर CS. अगेन पेशेंट रिफ्यूज्ड. वो तीसरे गायनेकोलॉजिस्ट के पास पहुंचा.
And by
सुबह 5 बजे से लेके 9 बजे तक वो 5 गायनेकोलॉजिस्ट के वहां गया. पांचों ने उसको सिजेरियन एडवाइस किया. अल्टीमेटली शी वेंट होम. और 10 बजे जाके होम में दाई ने नॉर्मल डिलीवरी कराई एंड बेबी वाज ऑल राइट. नाउ इन दिस केस दैट पेशेंट फाइल्ड ए केस अगेंस्ट ऑल 5 डॉक्टर्स. और केस काय का था? उन्होंने कहा कि डॉक्टर हैड ट्राइड टू एक्सटॉर्ट मनी
For cesarean
me under threat of losing my child. So under threat of death they tried to extort the money. And that was the case filed, and all five doctors were arrested. They had to take bail.
Oh my
तो कहने का मतलब ये है. So ये just एक example दे रहा हूँ मैं आपको. So we are into obstetric, and that's why I always quote in my lecture that these kind of cases should be documented and should be published in journals, so that if these are published in the journal, then they will become authentic that these things can happen, and later on our fraternity members can take help of these quotations in different journals that this can happen, and for these type of cases we cannot be held negligent.
Very
तो
true.
कभी भी कोई ऐसे केसेस होते हैं जो बिल्कुल ही अजीब केस हो तो दे शुड बी डॉक्यूमेंटेड. केस शुड बी डॉक्यूमेंटेड एंड इट शुड बी पब्लिश्ड इन द इंडेक्स जर्नल.
तो इस केस को कौन डॉक्यूमेंट करेगा? डॉक्टर्स ने तो रिफ्यूज कर दिया था. द दाई कैन डॉक्यूमेंट.
नहीं, we will document. अच्छा, Dr. Taru, you wanted some question? Dr. Taru, a question from your side?
Doctor, we have a make before we go on to anything. 2 procedures, vacuum and followed by forceps, not to be encouraged.
Should
This
not
is
be
no,
encouraged.
no obstetric practice.
मैडम रास्ते बहुत हैं डिफेंड करने के. ऐसा नहीं होता है कि नॉन डिफेंडेबल कोई केस हो अनलेस के यू आर ग्रॉसली नेग्लिजेंट. आप मॉप ही भूल जाओ. मॉप भी भूल जाते हैं ना लोग एब्डोमेन में, उसमें भी डिफेंड तो किया जा सकता है. सारे केस अनडिफेंडेबल नहीं होते हैं.
So,
circumstances play the role.
thank you, sir, for your nice take home message and the real practical points ki what we have to do it. Now,
डॉक्टर राजकुमारी, मैं डॉक्टर अभी डॉक्टर मैडम ने कहा कि बहुत सारे रिलेटिव्स इधर उधर से आ जाते हैं और कहते हैं मैं ये डॉक्टर मैं फलाना, आप थोड़ी देर और ट्राई कर लीजिए. तो ऐसे में मैं ऐसा कहती हूँ कि आप ना साइन कर दीजिए कि आप जिम्मेवारी लेते हैं. कुछ भी बच्चे को होगा तो आप जिम्मेवारी लेते हैं तो मैं कर लूंगी ट्राई. देन दे सरेंडर. ठीक है. हाँ कि आप कर दीजिए ना. आपको लगता है और वेट करना है तो आप साइन कर दीजिए कि हाँ आप वेट करिए और आप रिस्पॉन्सिबिलिटी बेयर कर लीजिए. Then they just disappear. Then they say, okay, whatever is happening, let them do it. Okay, that's all I wanted to say.
yeah, that's a good valid point. So we move further to the case 3. Instead of Dr. Shakuntala, I think anyone can take up this case. She's a gravida 2, para 1, lib 1, 34 years old, no history of GDM in first pregnancy. Average baby weight, she had spontaneous vaginal delivery. In the current pregnancy, all the ultrasound in all the trimester, there was no fetal abnormality reported. But in the 3rd trimester, there was mild hydramnios. First and second trimester screening for GDM was negative. In fact, there was no family history of GDM also, diabetes also. And in the third trimester, OGTT was impaired. She had a spontaneous vaginal delivery, but the baby was cyanosed just after the birth, had multiple birth defects, which were Fallot's tetralogy, anal atresia, teofistula. Surgical correction for the anal atresia was done, but the baby died within 3 months. Who can be sued? Question: sonologist or obstetrician? And what stand to be taken by the sonologist if he has missed the defects on the repeated ultrasound? Anyone can take up the case.
I think with the
I think the patient will sue both. Both, because
the choice of the patient.
It depends on the patient.
Yeah.
What the patient wants to see.
Then the next will be ki how the obstetrician can defend the case. Is fetal echocardiography mandatory in all cases of GDM? And what relative other investigation are must to prevent litigation in GDM?
So the first question is, how is the obstetrician going to defend the case? So definitely the congenital anomalies which have been missed are due to the failure of detection during ultrasonography. And at the same time, we also know that not all congenital defects can be picked up during ultrasonography also. So as far as the doctor is concerned, the obstetrician is concerned, she can always say so, that these ultrasounds were done by the ultrasonologist, and also that not all cases can be picked up. And also this also tells us that we should at least send the NT-LB scan and the level 2 scan to the best ultrasonologist available in our area. Very, very important. Because many a times the reports vary so much. If you send it to an average ultrasonologist, and with all due respects to everyone, and either we do it ourselves, there is a vast difference. And also, if there is a case, suppose this case was already a case of GDM, we should communicate this to the ultrasonologist, and also ask the person, the ultrasonologist, to tell us koi CVD, koi CHD to nahi hai, koi atrial septal defect to nahi hai. Look at the head properly and please comment on it. We have seen this, and there is no such pathology available. So this is my take on it. And doctor, over to you, Dr. Sir.
Dr. Sharda ma'am, you can also just narrate your experience regarding your case, because that was also the ultrasound missing of the congenital heart disease, if I remember.
What is the definition of best ultrasonologist? How can you say, you know, there's no way you can say
fetal medicine specialist.
There is no degree of fetal medicine in India, madam.
Doctor, there is nothing to do with the GDM. Patient had 3 abortions earlier. This time, you know, this ultrasound was done, an anomaly scan was done by the expert in the city. Then Dr. Jyoti suspected there may be some problem in the heart. Again, she had an echo from the best in the city, and it was missed. It is missed or miss. Koi bhi aadmi miss kar lega, doctor.
Even the best can miss.
Best can miss. And the child definitely had a little stormy neonatal period, but this child is thriving well, going to the normal schools and everything of this kind. But that those people have sued Dr. Jyoti as well as that ultrasonologist, and I happen to be there in the life care center. They all automatically do it. Though it has nothing to do with me. But what I feel is these kind of things can be missed out. When it will be discussed, we will see how things are.
But ma'am, this says child died within 3 months.
No.
Madam's case is different.
Not enough. That has nothing to do with the GDM.
This is a real case scenario.
So basically, madam, missing anomaly is not a complication again, not a negligence always. So problem क्या है मैं आपको बताता हूँ. See, I have yet to see a case in which doctor has missed the anomaly and is punished severely by any of the court. लेकिन कौन से केस में जजमेंट आता है अगेंस्ट में डॉक्टर के? डॉक्टर ने लिखा है all 4 limbs normal रिपोर्ट में, और बाद में बच्चा एक हाथ के बिना पैदा हो रहा है, so that is negligence. So whatever you see, only report that much. पहली चीज
सर इसमें भी तो ये लिखा कि सब कुछ ठीक है बट द बेबी हार्ट भी,
वही कह रहा हूँ, अगर आपने लिखा है सब कुछ नॉर्मल है, आप लिख रहे हो हार्ट इज नॉर्मल, और उसके बाद फेलट स्टेट्रोलॉजी आता है तो नहीं चलेगा, देन यू आर नेग्लिजेंट. बट अगर आप ये लिख रहे हो कि सारा आप रिपोर्टिंग दे रहे हो, लेकिन आप कह रहे हो कि आई कुड नॉट सी द लेफ्ट लिम्ब, और ड्यू टू दी पोजीशन बच्चे की ऑड है, या उसमें लाइकर ज्यादा या कम है उसकी वजह से, whatever it is, whatever is the reason, I could not see the left limb. So whatever you have seen, only report that much. उससे ज्यादा रिपोर्ट मत करो. लेकिन प्रॉब्लम क्या है कि मोस्ट ऑफ द डॉक्टर्स हैव प्रिंटेड कॉमन रिपोर्ट, और उसमें सब में नॉर्मल चला जाता है. ऑल 4 लिम्स नॉर्मल आपने लिख दिया. एक इंदौर का केस है जिसमें एक सोनोलॉजिस्ट ने सोनोग्राफी की थी, उसमें उसने लिखा ऑल 4 लिम्स नॉर्मल. बाद में जब बच्चा पैदा हुआ तो उसको एक लिम्ब नहीं था. अब उस केस में डॉक्टर एस सुरेश ने, डॉक्टर खुराना साहब ने, डॉक्टर चंद्रलूला साहब ने, 3 बड़े डॉक्टर्स ने उनको एक्सपर्ट ओपिनियन दिया कि दीज एनोमली कैन बी मिस्ड ड्यू टू दी पोजिशनल, बच्चे की पोजीशन सही नहीं थी या लाइकर की अमाउंट सही नहीं थी, तो ये मिस हो सकती है. तो कोर्ट ने ये कहा कि these experts are biased experts. मैं भी मानता हूं कि मिस हो सकती है, मैं क्या मना कर रहा हूं, लेकिन इस केस में डॉक्टर ने लिखा है कि ऑल 4 limbs are normal. तो अगर उन्होंने नहीं देखा था तो नहीं लिखना चाहिए था.
ठीक बात.
So basically what we see, only that much we should report. What we don't see, we should not report. If we are not, अगर मैं कैपेबल नहीं हूं हार्ट को इवेल्युएट करने के लिए, so I should write in the report that I have not seen the heart anomalies. Then you cannot be held responsible for diagnosing the heart anomalies. But the thing is that people are writing that मैं तो level 3 scan कर सकता हूँ, मैं तो level 2 scan कर सकता हूँ, and then they don't write the report of anomaly. That is wrong.
सर ये तो हर स्पेशलिटी पे लागू होता है.
हाँ तो होता ही है ना मैडम, सब पे.
तो आप जैसे हार्ट डिफेक्ट मिस करने की बात है, तो जब वो नॉर्मल लिख रहा है तभी तो मिस हुई, उसको तो पता नहीं चला.
मैडम अगर आप हार्ट में लिख रहे हो कि हार्ट आप
नॉर्मल है तो इसका मतलब देखा आपने,
लिख रहे हो कि भी देयर इज नो सेप्टल डिफेक्ट इन हार्ट, उसके बाद अगर सेप्टल डिफेक्ट आता है तो दैट इज रॉन्ग.
एग्रीड, बट देख के उसकी वो कैपेबिलिटी नहीं है डायग्नोसिस की ना.
नहीं तो वो गलत नहीं कैपेबिलिटी है तो यू शुड नॉट डू.
You should have written advised fetal echo from an echo specialist.
No.
Madam, all cases,
but the heart is not being examined.
All cases of missed anomaly can definitely be defendable in the court of law, because in most of the guideline, NICE guideline में, ISWOG guideline में, even निकोलेट्स ने खुद की बुक में सब जगह लिखा है कि 30% of the anomalies cannot be detected even at full term. Full term में भी नहीं डिटेक्ट हो सकती हैं.
And top can be missed also, sir, in 50% cases.
UK में पूरी 11 guidelines बना रखी हैं. Anencephaly can be missed in 2%. Heart disease can be missed in 50%. Kidney problem can be missed in 70%. ये सब लिखा हुआ है डॉक्टर साहब.
तो ये लिखा है तो इसीलिए कोर्ट में डिफेंडेबल है. लेकिन अगर आप एनेनकेफेली के केस में आप लिखोगे कि हेड इज नॉर्मल,
बीपीडी मेजर कर लेते हो तो फिर
22 वीक्स पे, और आप फिर एनेनकेफेली आएगा तो यू कैन डेफिनेटली बी हेल्ड रिस्पांसिबल फॉर दैट.
करेक्ट, एग्रीड.
नहीं तो सर फिर लेवल 2 में हमें नॉर्मल तो लिखना ही है ना, या तो नॉर्मल लिखो या एबनॉर्मल लिखो.
लास्ट जजमेंट जो आया है कोर्ट का, नेशनल कमीशन का, जिसमें 1 करोड़ के ऊपर कंपनसेशन दिया गया है, उस जजमेंट में उन्होंने ये लिखा, देयर इज नथिंग लाइक लेवल 1 और लेवल 2 और लेवल 3 सोनोग्राफी. डॉक्टर कैन बी हेल्ड रिस्पांसिबल फॉर मिसिंग द ग्रॉस एनोमली इवन इन लेवल 1 स्कैन. तो आप ये नहीं कह सकते कि मैंने तो लेवल 1 स्कैन किया था तो एनोमली नहीं पकड़ी तो मैं रिस्पांसिबल नहीं हूँ.
डॉक्टर साहब ये वाली बात है, ये तो अति हो जाती है ना जज की. तो ये वाली बात है, लेवल 1 को आप लेवल 2 स्कैन तो नहीं बना सकते ना डॉक्टर साहब.
तो आप लेवल 1 का रिपोर्ट लेवल 1 की तरह देंगे ना मैडम. आप
हाँ लेवल 1 की तरह देंगे.
अगर लेवल 1 में आप लिख रहे हो कि स्पाइनल कॉर्ड नॉर्मल है,
नो यू विल नॉट राइट
नॉर्मल, तो अगर उसमें अगर बड़ा मेनिंगोमाइलोसिल निकलता है तो यू कैन बी हेल्ड रिस्पांसिबल फॉर नॉट डायग्नोस्टिंग मेनिंगोमाइलोसिल.
थैंक यू थैंक यू
तो आप बताइए कि फीटल इकोकार्डियोग्राफी जरूरी है इन ऑल केसेस ऑफ बीपी और ओनली इन द हाई रिस्क पेशेंट?
हाँ, in GDM I think it should be done.
हाँ जी,
In GDM it should be done, fetal echo.
Yeah, but GDM,
let me go around it.
मैडम, in India there is no standard guideline कि क्या जरूरी है या क्या नहीं है जरूरी, है ना? तो come out with some standard guidelines. Again, standard guidelines are double-edged phenomena. अगर आपने लिख दिया स्टैंडर्ड गाइडलाइन को इतना करना जरूरी है तो फिर वो जरूरी हो जाएगा. तो rather than doing that, you should make a common जो एडवाइस क्या करते हैं पेशेंट को उसका एक कॉमन फॉर्मेट बना दो और हर पेशेंट को उतना एडवाइस कर दो. अगर पेशेंट नहीं करवाता है तो पेशेंट विल बी हेल्ड रिस्पॉन्सिबल फॉर कंट्रीब्यूटरी नेग्लिजेंस. अगर आप सब में लिख दो कि 11 to 13 वीक स्कैन करवाना है, 16 वीक्स पे ये कराना है, 18 वीक्स पे ये करा सकते हैं, 20 वीक्स पे ये करा सकते हैं, 24 वीक्स पे ये कराना है, और उसके बाद आप पेशेंट को एडवाइस कर दो. अगर पेशेंट नहीं करवाता है तो पेशेंट विल बी हेल्ड रिस्पॉन्सिबल. अगर वो करवाता है तो ठीक है, अच्छी बात है. अगर उसमें कुछ आता है तो वी विल फॉलो दैट.
ठीक है.
so this is the hemoglobin A1C level, the risk of
आपने ये जो इको वाली बात करी, मैं थोड़ा सा इसका बोलना चाहती हूँ. When you ask people like डॉक्टर खुराना की इको कराना चाहिए, वो बोलते हैं हाँ हाँ डॉक्टर साहब जरूर कराना चाहिए. And you ask डॉक्टर दीपिका डेका की कराना चाहिए, वो कहते नहीं डॉक्टर साहब. अगर आपने एनेबली स्कैन में कुछ भी नहीं पॉइंटर नहीं दिया तो देयर इज नो नीड. नाउ बिटवीन द लाइंस यू कैन रीड योरसेल्फ.
Ma'am, I want to share something.
Madam, abhi recently I had been one conference where this panel discussion was going on, है ना? और पैनल डिस्कशन में फिटल मेडिसिन एक्सपर्ट, अभी बहुत सारे फिटल मेडिसिन एक्सपर्ट हो गए हैं, तो उन्होंने कहा कि ये देखना चाहिए, वो देखना चाहिए, ये करना चाहिए, वो करना चाहिए. और अल्टीमेटली वन ऑफ द गायनेकोलॉजिस्ट स्टूड अप इन फ्रॉम द ऑडियंस और उसने ये कहा कि आप लोग पेशेंट को एंटीनेटल पीरियड में लाख से 1.5 लाख रुपए का खर्चा करवाते हैं और उसके बाद भी आप उनको डेफिनेटिव डायग्नोसिस नहीं देते हैं और वो ऑब्स्टेट्रिशियन के सिर पे आके खड़े हो पेशेंट कि मेरा ये सोनोग्राफी का रिपोर्ट है 11 to 13 वीक्स का, इसमें डॉक्टर ने लिखा है कि 1 out of 100 चांस रिस्क है. फिर आपको ये ट्रिपल मार्कर का टेस्ट है, उसमें इतना रिस्क बताया है. फिर आपने 16 वीक्स पे NIPT किया, उसमें इतना रिस्क बताया है. उसके बाद एमनियोसिंथेसिस अल्टीमेटली करना पड़ा, उसमें ये रिस्क है. तो यू आर नॉट गिविंग अस द डेफिनेटिव डायग्नोसिस इवन आफ्टर दिस मच टेस्टिंग. पेशेंट लाख रुपया खर्चा करके भी, 1.5 लाख रुपया खर्चा करके भी ऑब्स्टेट्रिशियन के सिर पे आके बोलता है कि अब मैडम आप बताओ कि मैं इस बच्चे को रखूं के गिराऊं. अल्टीमेट डायग्नोसिस इज 1 out of 40 कैन बी डाउन सिंड्रोम. कोई गारंटी तो देता नहीं है डाउन सिंड्रोम है या नहीं है ना? अब 1 out of 40 लिखा होगा. हाउ ऑब्स्टेट्रिशियन कैन डिसीजन ऑन बिहाफ ऑफ पेशेंट वेदर टू कंटिन्यू दिस प्रेगनेंसी आफ्टर स्पेंडिंग दिस मच. So these kind of discussions are going on. So sometimes we are over-diagnosing, sometimes we are under-diagnosing. For everything, we cannot be held responsible.
Sir, the other point is, if you say that fetal echo, we all know cardiac defects ज़्यादा होते हैं GDM में, and ideally कराना चाहिए. But अगर आप guideline बना दो, तो सारे लोग दिल्ली में थोड़ी रह रहे हैं. आपके पास लोग
तो कह रहे हैं.
So guidelines cannot be made according to Delhi or Bombay.
Yeah.
Guidelines तो आपको रूटीन पेशेंट के लिए बनानी है.
यहाँ पे भी नहीं
जो
है.
पेरिफेरी में जो डॉक्टर्स काम कर रहे हैं, अभी एक डिसीजन आया है मैडम, शिमला के डॉक्टर हैं जो पेरिफेरी में अपनी ऑब्स्टेट्रिक प्रैक्टिस करते हैं, उन्होंने उनके यहाँ पे फिटल इको, ये फिटल वो नहीं है, मॉनिटरिंग नहीं है, वो डिलीवर करवाते हैं. अब उनके यहाँ पे एक पेशेंट को रात को 3 बजे फिटल डिस्ट्रेस हुआ, उन्होंने डिलीवर कराया, बच्चा अल्टीमेटली एक्सपायर हो गया. दैट केस केम इनटू दिल्ली फॉर एक्सपर्ट ओपिनियन. दिल्ली के डॉक्टर ने उसमें एक ने एक्सपर्ट ओपिनियन दिया है कि अगर आपके यहाँ 1 बजे तक उसको डिस्ट्रेस नहीं था, 2 बजे तक, 2 AM को आपने देखा है, तो सडनली 2:30 AM को एस्फिक्सिया नहीं हो सकता है बच्चे. इसका मतलब ये है कि डॉक्टर ने सही से पेशेंट को एग्जामिन नहीं किया और उस बेस पे दैट डॉक्टर इज हेल्थ नेग्लिजेंट. अरे डॉक्टर किन कंडीशन में काम कर रहा है आप वो तो देखो. आप उसको ये कह रहे हो कि फिटल मॉनिटरिंग डॉक्टर ने सही से नहीं किया, डॉक्टर ने स्टेथोस्कोप से देखा है, उल्टा आपको उसको प्रोटेक्ट करना चाहिए कि स्टेथोस्कोप से और डोपलर से जो एफएचएस देखे जाते हैं, है ना, उसमें मिस हो सकता है एस्फिक्सिया, उसको बचाना चाहिए। उसकी जगह आप लिख रहे हो कि सडन एस्फिक्सिया नहीं हो सकता है, डॉक्टर शुड बी हेल्ड नेग्लिजेंट और डॉक्टर हैड टू पे कंपनसेशन इन दैट केस डिपेंडिंग अपॉन दैट एक्सपर्ट ओपिनियन। सो एक्सपर्ट्स को भी मैडम मैं हमेशा बोलता हूं कि जो अच्छे सेंटर्स में काम कर रहे हैं उन इन मोस्ट ऑफ द केसेस द एक्सपर्ट ओपिनियन इज टेकन फ्रॉम द आइदर फ्रॉम द एम्स या ऐसे बड़े बड़े इंस्टीट्यूट के हॉस्पिटल में जो काम कर रहे हैं उनसे लिया जाता है, और उनके एक्सपर्ट ओपिनियन आप देखोगे तो वो ऐसे होते हैं कि जैसे वो स्पेशलाइज्ड डॉक्टर देते हैं ओपिनियन कि अगर इतना किया होता तो शायद ये नहीं होता। इन वन ऑफ द केस इन लुधियाना देयर वाज a case of meconium stained lichen. Doctor did immediately cesarean section. Pediatrician was present at that time of delivery. बच्चा मर गया, एक दिन बाद बच्चा मर गया। डॉक्टर पे केस हुआ, पंजाब मेडिकल काउंसिल के एक एक्सपर्ट डॉक्टर ने ये ओपिनियन दिया कि अगर डॉक्टर ने 10 बजे पीवी किया, 2 फिंगर पे मेकोनियम आया है ना 10 बजे, अगर डॉक्टर ने 2 घंटे पहले पीवी किया होता तो शायद she could have diagnosed meconium like early and the baby could have been saved. तो if and buts के ऊपर opinion आ रहे हैं, and depending upon that opinion that doctor lost the case in state commission in Punjab. Ulta, we had produced multiple documents that even if there is meconium stained liquor, the FHS can be normal regular FHS. Only meconium stained liquor cannot be the diagnosis of fetal distress.
कंपटीशन है
नहीं,
सर।
वो तो आपका जो केस था जो 5th होम डिलीवरी होगी, 5 डॉक्टरों के पास जाके भी
ओपिनियन देने वालों की भी ट्रेनिंग होनी चाहिए।
Yes.
ओपिनियन देने वालों की भी ट्रेनिंग होनी चाहिए।
मैं हमेशा 40% दिखाता हूँ कि डॉक्टर इज बिहाइंड डॉक्टर। Doctor are losing the case in the court of law only because of expert opinion given by our fraternity member in the court of law. So we have to be cautious enough in giving
मेरे केस में भी तो यही हुआ था।
Sir, while giving opinion, we want to be proving ourselves most intelligent.
Yes.
That is the point. हमें सबसे ज्यादा knowledge है, इसलिए we should show that knowledge.
Dr. I want to share something.
ये करिए लोगों
हाँ जी, जरूर शेयर करिए।
मैम कि एक पेशेंट अभी मैंने सिजेरियन किया है, वो डॉक्टर रूबी की कजन थी। लेवल 2 अपने फीटल मेडिसिन कराया और इको नहीं कराया, और अभी जब ये बेबी बॉर्न हुआ तो बहुत छोटा सा SD आ गया उसका। अब वो रूबी मुझे बोली कि क्या यार तुमने फीटल मेडिसिन से कराया और तब भी तुम्हारा हो गया, इको क्यों नहीं कराया? मैंने कहा जरूरत ही नहीं, GDM तो थी नहीं वो, और अगर कराते तो वही प्रॉब्लम होती। तो जब वो कह के गई तो मेरा दिमाग थोड़ा खराब, तो उस दिन जो पेशेंट आई थी उसको मैंने फीटल इको मैंने कहा करा ले। अब वो आज आके मेरे से इतना लड़ी है। जब हमारा ये लेक्चर शुरू हो गया था तब एक्चुअली उसी से लड़ाई कर रही थी। लड़ाई क्या कर रही थी, उसको समझा रही थी, काउंसिल किया, बड़ा दिमाग कूल रख के वो खूब कि क्यों करेंगे इको, आप क्यों करा रहे हो, क्या कर लोगे, अगर छेद निकल आया तो क्या आप ट्रीट कर दोगे, ये कर दोगे, वो कर दोगे। समझाना मुश्किल हो गया कि मैंने कहा भाई तुम मत कराओ। कई लोग कराते हैं फीटल इको, हर एक का कराते हैं, लेकिन वो पेशेंट से अल्टीमेटली आई टोल्ड कि तुम मत कराओ, कोई दिक्कत नहीं है, चले जाओ। बट आई एम जस्ट शेयरिंग दिस बिकॉज देयर आर
फीटल इको के बाद भी ये बड़े जो सबसे बड़े सिटी में वो लिखते हैं 50% हार्ट डिजीज कैन बी मिस्ड आउट। आपने भी 50% लिखा और वो भी 50%।
मैडम सारे रिपोर्ट में एक बहुत अच्छा वी हैव टू ऑलवेज प्रिंट डिस्क्लेमर। दैट डिस्क्लेमर that is the guideline given by me always in my lecture. एक अच्छा डिस्क्लेमर होना चाहिए। उस डिस्क्लेमर में आपको सारी शॉर्ट कमिंग्स आपको लिखनी है कि ये मशीन की शॉर्ट कमिंग है, ये इतनी अनोमलीज मिस हो सकती हैं। आप बेस्ट डॉक्टर भी चाहे सोनोग्राफी करेगा तो भी इतनी अनोमलीज मिस हो सकती हैं। सो एवरीथिंग शुड बी मेंशन्ड इन दैट डिस्क्लेमर।
So I just
आज का medical legal discussion was very thanks to Dr. Geetendra that along with discussing the GDM, we could learn so many things as far as medical legal concerns are concerned. Thanks a lot, and so many take-home messages that it is हमको उनको दिल से ही याद रखना पड़ेगा. I cannot practically revise them, but the thing is, counseling is very important. The consent of vacuum and forceps is again important, but if you can prove the emergency or it is real emergency, then we may avoid it. Otherwise, if patient is in a condition to give the consent, it is always a very good defense for us in the court. Law cannot teach us medicine, but we can teach law medicine. So our defense has to be perfect as far as all the cases are concerned. As far as the medical issues of GDM are concerned, early screening, diagnosis, proper regular investigations and control of blood sugar is very important. Comprehensive multidisciplinary approach and timely referral to higher center if associated morbidities and uncontrolled blood sugar or high blood sugar dose of insulin is required. Avoid non-indicated induction of liver before 39 weeks of gestation. Antenatal counseling, communication, documentation, and informed consent. Again, the question mark on informed consent, because it is informed counseling, it is not informed consent. In India, we need a real and valid consent. So only informed consent is not of any use. It has to be a valid consent. Close monitoring of maternal and fetal surveillance, both antenatal and intrapartum, is required. Early detection of fetal distress and timely cesarean or operative delivery is a must. Proper record keeping and refusal of consent. Today we discussed a lot about refusal of consent. So it is the refusal of consent, it is the refusal of referring to the patient, it is the refusal of not giving the consent that you are responsible for the condition of the baby. So
and refusal of not getting shift from the hospital.
Yeah, refusal of. So we have to take that we could have done this, we should do this, and we have to learn more hard words to say to the patient if we have to save ourselves legally. Thanks a lot, Dr. Geetendra, and all the panelists.